My name is Nalini Rajamannan, and I am a cardiologist, and I work at Most Sacred Heart of Jesus Cardiology and Valvular Institute, and I have a secondary appointment at the Mayo Clinic in biochemistry. And the name of my presentation is the NHLBI Working Group Update, the Chairman's Perspective. And my talk was on the working group that which NHLBI began in 2009, bringing scientists from all over North America to study the mechanisms of calcific aortic stenosis. So they had bioengineers, imaging physicians, epidemiologists, and basic scientists. And we put together a position paper which was published in Circulation in 2011, and then the NIH granted 10 grants a year later in the field of molecular biology of aortic valve disease to try to really promote the concept of developing targets towards medical therapies to slow progression. And over the past 9 years, the field has really evolved, and studies are increasing, and the research is growing in this field globally. What's important, though, is that all the trials, the randomized trials, have been negative in terms of randomizing patients with aortic stenosis to statins versus no statins, except for one open-label trial out of Portugal, which was positive, which showed that rosuvastatin was able to slow progression within the allotted time period in patients who had elevated LDLs. And one other sub-analysis, which was performed by the SEAS group this year, published in American Journal of Cardiology, demonstrated that patients also with high LDLs that were randomized had slowing of progression. So there is a trend towards understanding that in this complex disease mechanism where you have a large biological target of the aortic valve, that there's a potential for medical therapy, but yet there has not been any definitive trials. So the NIH this year put together another RFA and about to award 5 more grants in this field to try to really develop future targets of cellular therapies and to try to slow progression. So really what I did today was present an overview of the field dating back to 1968 with the original paper by Ross and Braunwald, which showed that with the timing of severe aortic stenosis and the symptoms of chest pain, shortness of breath, and heart failure, that patients need to have intervention in terms of slowing progression of their their timing to mortality and morbidity. And now in 2018, so really 1968 to 2018, we have come a long way in terms of understanding the risk factors, which include traditional risk factors such as hypertension, smoking, male gender, metabolic syndrome, hyperlipidemia in terms of native valve disease, and also looking at cellular pathways which are very similar to coronary artery atherosclerosis. And then trying to understand how we're going to develop our trials. So which targets are we going to use, how are we going to choose our patient populations, and how are we going to target this disease process. And currently, the only treatment still is surgical valve replacement or transcutaneous valve replacement with SAVR versus TAVR versus mechanical valves. But yet the data is showing that these biological valves still are at risk for calcification and subclinical thrombosis. And also the risk factors, it just came out in JACC 2 weeks ago, that the risk factors for bioprosthetic valve hemodynamic deterioration is due to dyslipidemia. So I think in the future there's a lot of optimism at the NIH, a lot of optimism in the field of calcific aortic valve disease in terms of understanding targets, potential therapies, and developing large global clinical trials to slow progression of this disease.